I'd like to introduce our speaker for today. Dr. Julianne Serovich is Dean of College of Behavioral and Community Sciences for the University of South Florida. I apologize, that's Serovich. I want to make sure I pronounce it correctly. Dean Serovich is a graduate of Loyola College in Baltimore and has her doctorate from the University of Georgia. She has research which focuses on the relationship between HIV disclosure to family, friends, and sex partners, and the effects of sharing such information both on reducing HIV transmission and building social support structures for those coping with this illness. Her work has resulted in more than 60 book chapters and peer-reviewed publications. And we thank you so much for being with us this morning, Dean Serovich.
Thank you very much for inviting me. I appreciate the opportunity to discuss my research and discuss some of the outcomes and maybe make some suggestions regarding disclosure and how we can assist people that become diagnosed. The research I'm going to talk about is really a result of over 23 years of looking at disclosure rates, patterns, trying to understand what happens with individuals in terms of monitoring their disclosure and monitoring their reactions to other people's reactions to their disclosure. So I'll be presenting data today from primarily studies that I've done with women. However, there's some studies that we've done with men that we really haven't seen too much difference in terms of disclosure strategies that I'll be sharing, although they were developed with male populations. So it's a pleasure to be here. I look forward to the hour and any questions that you might have. So basically what we're going to do today, here's kind of an overview. I'm going to talk a little bit about the importance of disclosure, and we'll look at rates of disclosure patterns over time, and I'll be comparing that to both to men, because the women's disclosure patterns are significantly different than what we're experiencing in male populations. Talk a little bit about how we intervene, and then end with some specific strategies that we have found very helpful. Currently, my work has resulted in a grant that we just received this past summer to help men and women disclose their serostatus to family. And this is an intervention that revolves around assessing rewards and costs for disclosure, and then assisting them with developing a strategy. So I'll be sharing some of the information, although the project has just got started, and we've started recruiting January 1, and we've had a really good response. So while most of these strategies don't have an evidence base behind them, we have seen them be successful in small pilot studies we ran a number of years ago, and so we're hoping that with this larger clinical trial we'll be able to more clearly demonstrate. But I think most of what I'm going to be presenting will ring true for many folks here in the audience. So the importance of disclosure. This is something that I think many of you already know, and it's actually people out in the fields that have been talking to me about this. The nurse practitioners, physicians, people working in mental health centers, working in health departments, have reiterated over and over to me that disclosure is one of the very first things that people come to talk with them about after diagnosis. They want to know, who do I tell? Who's going to be safe? Who do I have to tell? What am I going to do with this information? And it's very stressful. Just thinking about the whole process of releasing this health care information can be create a lot of anxiety, a lot of stress, sleeplessness. We've seen a lot of depression and other kinds of outcomes associated with those people who are working, trying to figure out the process in which they're going to engage in disclosing. The degree of stress we found really does vary. And I'll talk a little more in terms of women. Disclosing to their sex partners is something that we find that they do relatively quickly. But however, there's a lot of anxiety with it. But there's even more increased anxiety in deciding to tell their children. And so the target of who they're going to disclose to does make a big difference in terms of how they feel emotionally. Every disclosure has an associated risk, consequence, and reward. Oftentimes, when we see our patients, they can readily identify what the risks are: rejection, being abandoned, experiencing violence, getting cut off either emotionally or financially from their support network, family, their friends. They get scared. They're very concerned about losing control of the message. They worry that once the words come out and somebody else knows, they don't control the message anymore. And this is true. And that, again, it's a cost, as well as many people feeling shameful, like they did something wrong, they're dirty. We hear all kinds of other costs. So individuals can readily identify the costs, but it's the rewards that we find in our program, our project, that we're able to help them think through. For example, having a deeper relationship with the target, having it feel cathartic, having a cathartic effect, not having secrets, being honest and open with their most trusted relationships, having support. If it's not going to be, if they're not going to get cut off, then more times than not they get more additional emotional, financial support. People report a decreased level of anxiety, an increased level of relief, and in fact, we've published studies that have shown that very few people actually regret the disclosure once it occurs, but it's the tension, the building up and anticipating the reaction that is more demanding. But we've shown and demonstrated to our participants that the relief and the very low level of regret is very satisfying. Also, by disclosing, people can access other resources that they might not be aware of, and they themselves then become very powerful and can become powerful if they choose to, of course, advocate for reducing stigma through the education of others. And so, again, people can readily identify the risks, but it's the rewards that are just as substantial. And in fact, once we get people to think through these rewards, there is a sense of just feeling a little less anxiety around what they're going to be doing. So let me talk a little bit about rates of disclosure. And this is basically the timing. And we're talking about timing because initially individuals may not, people vary in terms of when they disclose the information and how they decide to disclose over time. And I'm going to use let's start off looking at men as a comparison factor. So here, this is cumulative disclosure curves, disclosure to family by men. And what we find is that within 1 month of diagnosis, men disclose to about 42% of their mothers within the first month, and then about 50% within 12 months. That's that top dark line. So around 12 months, they got to about a little over 50%. If you look at the brothers and sisters, there's only about 40. It's a lower curve here. The straight line is the fathers, and the dotted is the sisters, and then the very bottom one is the brothers. Only about 40 to 45% of brothers and sisters are disclosed to within the first year, and only 40% of fathers within the first year as well. And I apologize, I got that reversed. I apologize. That very bottom line is fathers. The dotted line is sisters, and then the brothers is that broken line. I apologize. There's after about 3 or 4 years, there's a real change in terms of siblings, and you'll see that for men, the rates of disclosure to sisters increases, while the rates to brothers really become stagnant. And basically what that tells us is that for men, thinking about once they make a decision within the first 3 or 4 years whether they're going to tell their brothers or not. If they've decided they're going to tell them, they're going to tell them in that time period, and then they're done. With sisters, it takes a little more time, and they gradually increase the number that they tell, but it just takes longer. So with sisters, it's a little more variable than it is to brothers. And with mothers, it consistently increases. And at about 6 years or so, 80% of mothers are disclosed to, and then it pretty much levels out. Then they've made a decision. It takes a long time for that final one to be made for mothers. For fathers, we see, again, we have a pretty quick increase, and then between 4 years and 6 years, there's a gradual jump. So this is how men disclose, or the rates in which men disclose. This is the disclosure for women. So in contrast to men, 60% of all mothers are disclosed to within the first month, and there's almost 75 within the first year. So it's much more rapid in terms of disclosing to their mothers than men. The same thing occurs, that yellow line are sisters. You see it starts up much higher, and it has a very steady growth over time. Brothers, the blue line, it starts off about the same as with fathers. It's a very gendered experience for women. So fathers and brothers about the same time, but then they break off, and there's a more rapid disclosure to brothers, and that's again these are down here are months versus the years, and then it increases at pretty much the same rate, brothers and fathers. So what this tells us is for women, there's an immediate need to get it off their chest. There's more immediate needs to disclose, and they than compared to men. So when we think about intervening with women, the earlier that we can get information, the earlier that we can talk with them, the better. They're going to need this kind of information about disclosure much more quickly than men, who take a lot more time to think through the process. And here's another way of looking at of women's disclosure. You can see here again, in the first month, 46% of family of origin. In this one particular study that we did of about 125 women who had almost 400 family members. In the first month, 21% of children, and then it goes down the line. Partners, 45%. And so, again, very rapid. We have to get information to them very quickly. And then at a year, for family, 68%. Children, it's 43%, but that's an age issue. We'll talk about that a little bit later. But 75% of all partners after the first, 2 years have been disclosed. And partners, for the definition of this study, included ex-partners as well, not just current partners. So it was their casual partners, it was their exes, it was their current spouses. Current spouses, and I don't have this on this particular slide, but spouses were, as I recall in our data, within 6 months, like 95% of all current spouses had been disclosed to. And a lot of that is because people got tested together, or they just went right home and encouraged their spouses to get tested. It's a very interesting phenomenon, and again, we can hope to pick up on that a little bit later. So you see the rate of increases over time as well. So there's lots of things to consider around intervening. And it's most beneficial, although as you can see, they need the information quickly because they're going to act very quickly. They need that support. There's a lot of issues that they really need to be considering and thinking about pre-disclosure. And pre-disclosure time is, again, there's lots going on, so it's very challenging for them, and it's hard sometimes to sit down and think methodically through some of the issues that I'm going to talk about, but we really do need to encourage them to take a deep breath, think through some of these issues before making that decision. We believe that what we're hearing, what we know is that individuals who make very knee-jerk, very reactionary disclosures are the ones that have the worst reactions because they haven't prepared themselves and they haven't prepared for the reaction of others. So the knee-jerk disclosures tend to not be as positive in terms of outcome than ones that are more methodical, people can think through. And again, this is what our intervention does. And these are things that any of you could be doing in your clinic, and it applies to just about any target. Some of these are target specific to children, target specific to sex partners, but for the most part, these are issues that can apply to any potential target for disclosure. So, first of all, we all need to understand, as do our clients and our patients, that disclosure is a process. It is not necessarily an event. And even before they tell the first person, they have to work themselves through a process. And for children, it is definitely a process because we have the issue of age, as I mentioned earlier. Children who are too young to understand may be told that mommy's sick. They don't necessarily have to be told the full information. Later on, as they get older, more mature, mommy's sick and takes medication every day, has to see her doctor, but she does a really good job, or whatever the situation may be. As they get older, then more information can be provided in terms of the diagnosis. So it is not specifically an event. As I talked about earlier, it does require preparation. And when we talk about the strategies, there's a wide variety of them, and they vary depending on the personalities, not just the, basically what I mean by that is it's about the relationship, and it's about the other person just as much as it's about the woman. And we oftentimes don't consider the personality, the life, what may be going on with the person that's going to be disclosed to. So these are some questions that we've designed and we believe that are very beneficial for women to consider before disclosing. And first of all, more accurate is how comfortable is she with her diagnosis? If there's a great deal of anxiety, or is there not a great deal of anxiety? Did she have some idea that this was going on? Did she have some clues? Is she feeling okay? She just needs to be aware of whether she's really in any kind of good place with it. And 6 months, sometimes a year, as you saw the patterns over time in those disclosure rates, for many women, they need to come to a level of acceptance. Some don't. Some just say, I need to disclose because I need help to get comfortable, to get to that place. That's fine. She just needs to be able to identify where she is in that spectrum. Does she have the support that she needs? So this pertains primarily to partners or to parents if she's dependent on other people or whoever she's dependent on. If indeed there's a negative reaction, does she have some short-term or some long-term options? Does she have any support in terms of just going into this event? And so just being able to identify who can assist, is there anybody there that she feels will be maybe the first person, the first people to tell, maybe those that can make sure that she gets the support that she needs through the process. How knowledgeable is she about HIV? In our office, and over the years, it's always been stunning to us just how little people know about HIV. And I'm sure you all have experienced this very same phenomenon. So we need to get an assessment, give her some little bit of education. People, if they have the wrong information, they're going to share the wrong information with the people that they disclose to, and then this could indeed create far more problems than that could be eliminated if she just had some really good information about what's going on with HIV, what it is, how it can be transmitted, So knowing how knowledgeable and knowing whether that she can educate others that ask questions, because we know that the first thing family members do is they bombard our participants with questions, and it becomes even more overwhelming and even more problematic for the woman if she can't answer those, because not only is she trying to get something from someone else, but she's also dealing with the needs of the person that she's disclosing to. And so I'll talk a little bit more about that, but making an assessment about how knowledgeable that she is. If she's going to be disclosing to family, what's the emotional climate at home? How are things in general in the home? Is this a disruptive home? Is this a home that's high anxiety, maybe lots of chaos, or is it a more calm? What kind of environment is there? Is it more stable? Making that assessment will give her an idea of, again, how to approach the particular situation, and timing. Again, when we look at those rates over time, we have to wonder, is some of this just a timing issue, that there are other things going on that are not more important, but that don't make it conducive to a positive experience for her. Can she be patient with the reaction? Now, what we know about disclosure, again, as I said, that women have experienced, and so have men, very little regret. Men regret less than women. Women tend to regret when they're not the ones that disclose, and this is true for men as well, and when somebody else discloses for them. And so controlling that information, controlling the message is very important. But we also know that if they have a positive, if they go into this disclosure process with somebody, if they had a previous positive relationship, the person's reaction may be predictable, and that it's likely to be a positive outcome. But if the relationship has not been predictable or has not been very positive, then she may need to prepare for a not so positive reaction. Over time, however, the patience comes in here, is that what we found is that people react oftentimes very negatively, but over time they resolve the relationship. And so being patient and resolved with the fact that that person now has to come to their own level of comfort. They have their own process to go through, just like she did. And so we help our participants understand that the other person also has a process that they have to go through, and it may be very quick, it may be very private, it may not involve her. It may involve her indeed, and trying again with trying to have her solve and work through their issues with them. In that case, knowing where the support is for that person or support for her is very important. The motive, what is her motive right now for disclosing? What does she want? What does she need? What is it that she, what's the desired outcome from the disclosure? Is there something specific that she has, or she just wants them to know? Identifying that so that she, for herself, is very important, so she can ask for it. Even if the person at that point in time may not be able to provide it, may not want to provide it, then that could be, that's okay. At least she knows what she wants and she asks for that. There's a question that came up, and I think it's appropriate to answer right now, about race and ethnicity of the women that were studied, because in our studies, and primarily, and I don't have the numbers sitting in front of me, but these were primarily African American women. The studies were conducted in Columbus, Ohio. And so we had very few Hispanics, but they were primarily, off the top of my head, I would say that they were probably 75% African American and 24% Caucasian, and then maybe one or two that were of a different ethnicity. So, so that gives you an idea of the demographics for these women. Okay, so we were at, for the motive for disclosing. The general relationship with the family, again, it goes back to the climate at home is a little bit different than the relationship with the family. Are they close to them? Are they not close to them? If we know lots of people that for all kinds of reasons move away from family because their relationship's not good. So they might not care what their reaction is, or they may care very deeply about what the reaction is. So they may just tell them just to get it over with, and they don't care, they don't need anything from them. Or if it's a very precious relationship that they're worried about, then it may take them a little more time. It goes back to the issue of the emotional climate at home. The emotional climate at home is more around what's happening right now. Is there somebody, are parents divorcing? Did somebody just lose their job? It's that bigger climate, and how is the family or that group of people, whoever they are, reacting to whatever else is going on? And what is the person's moral, societal views? It's perfectly reasonable to say that this person's a very liberal person. This person's a very conservative person. For some people, religion plays a huge part in this, and for others, it doesn't. So making that assessment is very important. It doesn't necessarily mean that because they are somebody that has high expectations of themselves, high expectations of her, about and that have strong opinions about behavior, doesn't mean that they won't react positively. But there may be a way of thinking through how to disclose to that person, or reacting to their reaction to the information. So some general suggestions here, very general. First of all, we remind women all the time, they don't have to tell anybody. Unless they're having sex with them, they don't have to disclose to anyone. It's their private information, their mother, their father, their sister, their brother. They don't have to know. That's their information, and it's private to them. We empower them with that. We ask them to evaluate, again, the relationship with each possible recipient, and it's not a general, you might disclose in a group setting, but it doesn't necessarily mean that everyone's obviously going to react the same. And so what's the individual relationship? Again, reviewing any special circumstances that the recipient may be experiencing. As I mentioned earlier, if someone's going through a divorce, that may not be the time to tell that particular person. If the general overall climate in the home is fine, but that person is just having a really hard time with losing their job, having their own illness, losing another family member, a death in the family, then that's a really good reason to hold off and wait. Again, the recipient's knowledge, prejudices, and some anticipated reactions is important to assess. And we help women prepare almost a script of what they're going to say. And we divide it into 3 parts. And we ask them to think about, first is, and don't make this a long drawn out scenario unless you're not sure what the person's reaction is going to be. If someone's reaction is going to be potentially negative, then you might, and we'll talk about strategies. There's a strategy for dealing with that. You might want to take a little bit longer, but prepare your words and exactly how you want to do it. The very first piece of it is how you want to start the conversation. Then it's the middle about deciding what you're going to disclose about yourself, what questions you will answer, what you might want from that person. So that's the middle piece of the conversation. And then the end piece of the conversation is, how are you going to end it? Do you want to ask for, can I come back and talk to you later, or do you need to end it abruptly and leave if it's not going very well? So how are you going to start the conversation? The middle piece, what are you going to be, is there something you want to ask for? Are there constraints around what you're going to disclose, like how you became infected? Is it important that this person knows that you're on medications, and is there an ask of them? I need something, and that's in the middle part of the conversation, and then how you're going to end it. And we encourage, especially for those that, again, that think they're going to be a potentially very negative reaction, we encourage them to have either somebody with them or have an escape. That you can get up and just walk out of that conversation. If somebody doesn't want to end it and they just want to keep going on, you can end it by leaving. And so those are the three parts. And we encourage them to if you think it's going to be pretty quick and easy, get to the point pretty quickly. We encourage and we provide to our participants information packets about HIV. It's basically an FAQ. You know, what is it that people might ask and that you either don't want to answer it right then and there, or you're not knowledgeable enough to be able to answer it? Give them this information about HIV. And that oftentimes will take off that barrage of questions that if people just don't, and they don't want to hear. Obviously, disclosing under the influence, either them or the recipient under the influence of drugs or alcohol is really discouraged. It just exacerbates any negative reactions or even positive reactions. It can elongate the conversation, and it's just not advisable. And so we encourage people not to do that. If there is a fearful of a negative reaction, we have a safe person with her and a safe place to go right then and there, especially to the sex partners. If it's safe, obviously a private setting. If it's not safe, a public setting is fine. A public venue, people are less likely to. Now, I don't recommend bars because, again, we get the alcohol issue. So private, the setting really does depend on the person and the potential reaction. And again, people are not prepared for the barrage of questions that they get. So we really try to make sure that they're ready for that and that they're ready to assist the other person with it as well. So now we talk about some strategies, and these are things that primarily we've learned from men. However, we have found that many of these, there's no difference in terms of men and women utilizing them. I think you'll see as we go through them that these can be used for just about anybody. Some of them are more specific to sex partners because, again, with the men that we were working with at this time, that was one of their biggest concerns, was how do I disclose and not transmit the infection to somebody else. And so it's somewhat skewed in that direction, but I think you'll find that I know our participants love this, and these are the strategies that they feel that they never even thought of. Most of them had never even thought about it, or they hadn't even considered, and they go out and utilize, and we got very positive reactions on our current study. Right now we're running a current study based on these strategies with men who have sex with men. And although we haven't dived into the outcome data yet, we know that our facilitators are coming back with very positive comments, and we know that we prepared a menu of these strategies for our participants in that study, and they're taking handfuls of the menus and kind of taking them with them. So we know that that on the surface, at least, that they're desirable. So we categorize these into 4 different domains. These can be what we call point-blank disclosures, stage-setting strategies, buffering strategies, and seeking similars. And the seeking similars, again, is more around sex partners. So we'll begin with the point-blank disclosures. This is a very direct disclosure. There's an overt expression, I am HIV positive. It can occur in just about any venue, any vehicle that the person might want. Most common for our participants is directly in person. But again, if people are fearful, we know we have a lot of instances of people doing it over the phone, in an email, whatever, just as either a practical problem because the person doesn't live nearby, or as a personal safety strategy. So here's an example. this guy says, I tell people up front, I don't wait for the spirit to move me. I just tell people. If we're sitting in a bar having a drink, they say, do you want to go back to my house or do you want to go get a hotel room? I go, look, I'm HIV positive. I have been for over 20 years. That's the way it is. Deal with it. Don't deal with it. I really don't care. So this is a very aggressive, as you can see, approach. It is a person that is very comfortable with who they are. They are very settled with themselves, and the reaction of the other person is completely immaterial. We don't have too many women that are as comfortable with this initially. It's these kind of disclosures that oftentimes, as he said, I've been diagnosed for 20 years, that occur much later on in that trajectory that I showed you regarding rates of disclosure. These are strategies that oftentimes occur way out there. Now, this is also about a person's personality. We know people who can just walk into a room and say, this is who I am, deal with it. But it doesn't have to be quite this strong. These are, for the most part, in the initial years, months of disclosure, are some of the most anxiety-producing, and they also, resolve around the most risk, especially if they're done in person. There's all kinds of risk associated. In our studies, we haven't seen a lot of violence towards women. However, some studies that have been done in South Carolina have, and other places, not just, have shown that there is a fair amount of violence that does occur, and this is why having somebody else there is just very important. Knowing the personality of that person and the whole preparation for the disclosure is very important. But these, again, pre-planning can eliminate many of these more aggressive reactions. Stage setting is very interesting, and this is the one that most people don't think about. And everyone thinks, well, I can just come right out and tell them. But this is a method by which we encourage people that if they're not sure of the reaction, to provide them clues that they may be HIV positive. And then typically it's a back and forth of, I'm not feeling well, I go to a doctor, I'm, just providing a little bit of clues. They might talk about HIV in a general sense, just to get the person's ideas around that or their reactions to it. And there are 5 strategies around this: verbal hinting, symbolic hinting, listing one's status on an online profile. This is for people who are, especially if they're looking for a partner. Asking the partner about his status first before telling your own, and insisting on condom usage. So verbal hinting is dropping hints that one might be HIV positive or opening a general conversation. It's meant to just gauge the reaction. So we're looking at provoking some comments from people. And on here it says a sexual partner, but this really could be anybody. This could be mothers, fathers, anybody, to get an idea of what they think about HIV. So as we say, it's testing the waters. And if you feel like you need to back out of it, you can back out of it, and you haven't told anybody. You haven't said it. You haven't done the actual disclosure. You can back out and say, oh, no, not me, and move on. And so especially with a family member, if you need to back off there a little bit, that's okay. This gives you the avenue to do that. It doesn't necessarily mean that the process is over. You can always reconsider the process, reconsider the person, figure out if it's ever going to happen, and maybe later. And again, when we look at those curves, we see that indeed many people stop and go. And this is a good strategy to allow that to happen in a safe way. So again, this is, we were flirting and talking, and he was making flirtatious remarks and stuff, and I said, well, you might want to have sex with me because I carry a little baggage. And he said, well, a lot of us carry baggage. And I said, well, you might not accept me for mine. And he said, well, you never know. We might be dealing with the same thing. So then at that point I said, I'm HIV positive and on meds, and he said, so am I. So you see the back and forth and give and take of this conversation, and it doesn't necessarily have to be just with a sex partner. It can be with anybody, like even talking with children about mommy's sick, and I'm feeling fine. Have you ever heard about HIV? Did kids talk about HIV? Have you ever? I mean, there's ways that this can go back and forth, and you can get some ideas of what's going on with the person. Symbolic hinting is a little less specific, and this is intentionally leaving out materials so that somebody sees it and might ask a question. People have told us that they put maybe posters up in their office or in their or information magazines in their home. They leave their medication out on purpose. They might have brochures sitting around or leaving things from the event that they went to, hoping that maybe that might spark the conversation. Again, just because you have one of these materials, now the medication's one thing, but just because you have these materials doesn't necessarily mean that you're HIV positive, so it still can give you a way out of this. The medication, a little less so. You're committing a little bit more to that. So here's an example. He went to the bathroom, and I had some related materials in the bathroom that was AIDS related. And he picked it up and said, you positive? And I said, yep, from the other room. It got quiet, and I said, you all right with that? And he said, were you going to tell me? I said, I left that in there in hopes that you would go in. So again, you can see how this is an indirect way of disclosing, but many people have found it more effective because they don't know how to bring up the conversation. For those people who can't figure a way to start the conversation, this is a really good way to start it. So and again, even backing out, if they decide they don't want to, you can say, well, yeah, it's in there, but that doesn't necessarily mean anything. Why do you ask? So online profiles, and this is basically, again, people who are seeking out sex partners, and we know that women, because they become infected, doesn't necessarily mean that they're going to stop having sex partners. It's drastically reduced, and a lot of times what women tell us is that they become abstinent, they don't have sex because they don't know how to disclose. They don't know how to tell that person. And so what we have found is, some people have said that we're promoting sex, but we're not. We're just saying that there are ways of being able to tell a sex partner and have it all be okay, and maybe even find a partner that is similar to you and have a healthy relationship. So for those that go online, we encourage them to put their status on that profile. And we, the other thing with this, of course, is that, we have laws around not disclosing to sex partners, and putting it on your status gives you some way of demonstrating, if it ever should come to that point, that you have disclosed that they're HIV positive. It's on your profile. People can look at that. They can go, criminal investigators, whatever, can go back and take a look at it. It's a whole lot easier. The same thing with doing things in letters, online, putting it in an email. You have some evidence of that. But oftentimes, especially for men, we ask that they make sure that the person actually saw that part of their profile. Because if they haven't seen it, then it doesn't mean that they're aware. And so people use this on their profile primarily to weed out people who aren't interested, and that's fine. And the disclosure then obviously becomes less risky because they already know you've told them, and they have decided not to even engage with you because of your profile. So here's an example. This guy was asking to meet me and possibly go to dinner or something like that, and I asked him, well, did you look at my profile? And he said, yeah. I said, well, did you really look at my profile? And he said, yeah. And he knew what I was talking about. And I was like, so you're okay with that? He said, yes. And we started to talk and found out that he was also positive. So again, this is a strategy that anyone can use if they're looking for partners online, and we encourage people to do so. Now, here's the other thing that happens with this, just as a little FYI on the side. What we find is that when people, well, let's see, how do I put this? It's Some people believe it's better off to start a relationship honestly. And so they will put it on the profile and they will keep it on the profile. Some people fear that they'll never get a partner, and so they set up maybe even two profiles, one that has it, one that doesn't. And so for men, at least, we know that the profile that, because you can do this, there's no limit to how many profiles you can have on some of these sites. So the one that has the status on, they call it their husband-looking profile, and the other one is their sex-looking profile. And so just as an FYI, that not everything you see on these profiles is necessarily true. So here's another example. I've had several encounters with one guy online. He listed his status, and we talked about, because they both were positive, he would come over. We didn't have to worry about the whole disclosure crap. It was all out and done. That's why we use chat rooms and let you announce your status to your profile. Most of us put it in. That's just another example. Stage setting, this is where asking, oh, no, let me back, I'm sorry. So asking a partner first is what we call the preemptive strike. And the preemptive strike is used when you want to, you can use it as getting the conversation started, like are you HIV positive? Or you can use it as kind of, well, yeah, it's getting the conversation started. It's trying to not put the pressure on that person, on themselves, and let somebody else answer the question first. And it does, people report that it does minimize a sense of being vulnerable by putting it on the other person first and seeing how they respond. Not that they'll tell you the truth. I'm not saying that they will, but at least you can get some sense of if they're going to come right out and say, yes, I am, or no, and I hate people that are. I don't want nothing to do with people that are. Well, that's good. That's good information. You've provoked that information out. So here's an example. So it just so happened that he had the same kind of lunch as I get because I'm HIV positive, and I found out, and I said, you're HIV positive, aren't you? He said, how do you know? And I said, I saw those lunches up there. And he said, yeah, I am too. And that's when it was disclosed. So condom usage is also, a really good way of bringing up the conversation, especially with obviously with sex partners, to begin the disclosure conversation. And we have people in our projects, whether they are sex workers or whatever, that just say, this is my policy. I always use my clients always use condoms, or I always use, it's a personal policy, I always use condoms. And it can provoke the conversation, and if it doesn't provoke the conversation, at least it keeps everybody safe. Buffering is a way of basically using somebody else or another or something else to facilitate, to do the disclosing for them. Now, as I said earlier, most people find that if they do the disclosing themselves, they feel better about it. What they don't like is when somebody else does it. That's typically to family members, and what usually happens is it's family members that they didn't want to know. And that's another legitimate thing that you can tell people, that people can ask for. They can't control whether the person goes out and tells their sister or their aunt or their grandmother, but they can ask for it not to happen and give a good reason why. But the buffering can protect them from disappointment, protect them from the reaction. Let somebody else deal with that reaction, and it's perfectly legitimate. Oftentimes people will utilize that. So, this example, he asked me to go to an AIDS vigil. A few of his friends had passed away. They do this candlelight vigil once a year. Prior to that, I'd asked him out for a drink or something, and our second date, we were at this vigil, running into all kinds of people I know, and it was just kind of intense, and I disclosed to him right there. You know the person is okay because they're going to an AIDS vigil. They're going to an AIDS event. You know that in this particular example, you know they're going to be okay with it. But there are other ways that, other buffering, other people, such as yourselves, that can do that for them. And we don't see a lot of examples. Well, I'll talk about that in a little bit. But a lot of examples of helping professionals being utilized, and I don't know exactly what that's about, other than people don't think to do that. But seeking similars is, again, putting yourself in a position, especially if you're seeking a life partner, a sex partner, to put yourself in a situation that could find other people very similar to yourself. So again, this is an example. I was networking with a black organization. They actually had a lot of stuff to do with HIV. So they kind of market to a lot of gay clubs and stuff like that. So I talked about HIV prevention, hosted parties. The two particular people that I met, they pulled me to the side and asked, are you HIV positive? And I was like, well, are you? So here are some strategies that were not mentioned. I'll go through them very quickly, but we've seen people do this: body art, tattoos, red ribbons, HIV, all kinds of body art. People wear HIV-related clothing that, again, evokes, and this is somewhat along the lines of symbolic hinting, and using disease intervention specialists, therapists, caseworkers, nurses, et cetera, that could help with the disclosure process. So now we're open to questions. So the first one says, before this presentation, I had a client who was Hispanic, and his wife recently came to the U.S. from another country. He has not told her his status. He said he was embarrassed to tell her. I suggested that he bring his wife here to discuss with the provider staff, and we also have peer mentors who speak Spanish. I think the message has to be tailored to the individual. This is an excellent way of handling a disclosure, and in fact, you could ask them both to be tested. He could bring her and just say to you that they both want to be tested, and he could act as if he hadn't been tested before. We have seen people that have done that. And actually, there are some health departments who see it over and over again, the same person getting tested with a new partner. But it's a wonderful strategy. You're in a public environment. You can answer the questions. You can deal with the stress. You can intervene. You can provide the support. I think it's a wonderful way of helping people and giving that support that they need in the very, at a time that's very difficult for them.
Dean Serovich, one question that I have, through practice, we noticed that our clients and patients that had disclosed to someone were more likely to stay in care and more likely to take their medications. Is there any research or data that you have seen that sort of applies to that?
We have had some small studies that are done that do suggest that those people that disclose are more adherent. And it really does make sense because they can leave their medication out, especially if it's people at home. They can get to their appointments if they need assistance with that. And then they don't have to explain to everybody why they're taking pills certain times of the day or doing what they need. So we do have some evidence. It's not huge, but there's all kinds of reasons to suggest that that would happen, that they would be more adherent if they've disclosed, especially to family that can assist them.
Good, thank you. There's one more question from Yvette Rivero.
Yes, I have a difficult time with our Haitian women disclosing to anyone. Any thoughts? Again, I would go through with them and discuss, with them, how they're thinking about this. What do they think when they think about telling their mother? What do they think about? Pick specific targets. When you haven't told your child. Let me talk a little bit about children, if that's okay, because this is especially prevalent for women. But if it's to a child and they're nervous, some things to consider are the age of the child, their level of maturity, what they know, how worldly are they? Are they involved in conversations and things that involve more mature topics? What kind of friend base do they have? Are their friends likely to be immature as well? Will they spread it around? Will they hold the secret? And because for most children it does become a secret. Then creating a group of people that they can disclose to and talk about this is very helpful for children, so that they don't have to look at their peer group and say, I can't tell any of them, who do I talk with? If you identify the people and have those people be available to them, friends or other family members, to discuss it with them, and not just discussing with the mother, can be very helpful. But again, for anyone who's fearful around disclosing, it's really it's very difficult. That it's sitting down and picking a target and saying, what's going on? You haven't told your mother. Well, why haven't you told your mother? And getting the story. You haven't told your father, you haven't told your sister, and looking for themes. What are they fearful of? And what we do in our studies is we identify the costs and we find ways to minimize that cost. I'm afraid that person will abandon me. I'm afraid that they won't have any more relationship with me. Well, have they had a good relationship with you up until now? If they have, it's most likely that they will. How can we build some support for them? What can we give them so that when you tell them, they're taken care of and it's not on you? Now, there are really legitimate times when disclosure should not occur. If, again, someone's really going to be violent, if they need the time to maybe become more financially self-sufficient, if they need the time to do to build up another support system, to move out, let them have that time. As long as, if they're working on it, it's not causing them stress or anxiety, that's perfectly fine. So there's a reason for those trajectories that I showed you early on in the presentation. People sometimes I need to get done with college, I need to get a job, my own apartment, I'm on my own, then I can tell them because if they do kick me out, my whole life isn't ruined. And so, if there is something really legitimate, support them. That's all you can do is support them. If it's something about again, as I mentioned earlier, well, they're going through a divorce. Okay, so let's plan what you might tell them after the divorce is done, after they get to a better place. And how will you know they're in a better place? If the idea is just because, well, she's going to get mad, well, then you have to really talk a little more clearly about, again, the nature of the relationship. Dig a little bit deeper, I think, might be helpful.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org www.florida.gov/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaatc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AATC in your region, visit www.aidsetc.org.